Hi everyone. Good morning, good afternoon, good evening. Myself, I'm joining from Nigeria. I'm Sabath Nobong, and I'm the director for the Boston Congress of Public Health, Thought Leadership for Public Health Fellowship. Yeah, that's a mouthful. So welcome to BCPH Thought Leadership for Public Health Fellowship, and this is something new that we're trying to ensure that or to see how we can use podcasts or live webinars like this to drive a message and bring that platform for our thought leaders to test the waters more like. So for the fellowship, why we are here is to ensure that we democratize the public health discourse, to give a platform for emerging thought leaders, no matter where you are in the world, from different backgrounds, ethnicity, race, to ensure that the public health discourse is not just for some categories of persons. We want to make it accessible for different categories of persons, no matter where you are in the world. So this is one of our new initiatives to see how we can use podcasting to create that platform or avenue for emerging thought leaders to champion their discourse. So you're welcome to the webinar series. So this is going to be happening between the next few weeks. We'll have different fellows of the fellowship come on here to sort of test run their podcast. So you, the audience, you're here to provide that feedback, to encourage them as well, to see how we can help with your feedback, help shaping their thought leadership journey. So welcome again. I'll hand off to Dr. Candace and Dr. Carpenter to introduce themselves. Then we get right on with the show.
Thank you so much, Sabath. So I just want to say thank you, Astrian, for being the first fellow to go ahead and do the inauguration of your podcast with the Boston Congress of Public Health. And thank you, Julia, for being the first guest. I'm Dr. Carpenter. I'm the co-CEO and Chief Strategy Officer for the Boston Congress of Public Health. But I will leave it there because it is not about me, and I'll pass it on to my colleague.
Hello, my name is, thank you very much for being here today. First and foremost, again, just to echo my colleagues, my name is Dr. Cersei Gray-LeCompton, co-CEO of BCPH with Dr. Carpenter. We're very excited to have this discussion today. And before my colleagues and I leave it to Astrian and her guest, Julia Reynolds, to have their discussion, just want to let everyone know if you have any questions, just put them in the Q&A or in the chat and we'll forward those along. Also at about 2 o'clock, there's going to be a pulse poll. So please be sure to fill that out. And then you'll also receive a survey. And if you wouldn't mind filling that out as well, we'd love to hear your feedback about this series, as will Astrian, who is obviously first up as our first Thought Fellow to do a live webinar in this cohort as well as in any of our cohorts. This is new for all of us. Thank you very much. So with that, without further ado, I will hand it off. And thank you again.
All right. So I'm Astrian. Just to say a little bit about myself, obviously I'm a BCPH Thought Leader Fellow. I'm also an intern with the Health Equity Institute of Massachusetts and previously worked in public health emergency preparedness out in Oklahoma. I'm currently based in DC though. So welcome to the webinar version of my podcast, In Case of Emergency, Preparing for Disasters, where we talk about things going catastrophically wrong in public health or how we try to avoid that. And today we have a lovely guest here to talk about public health emergency preparedness, community resilience, and what's going on with the Trump administration's attacks on all of those things. So to just do a little bit of an intro to what public health emergency preparedness is for those who aren't familiar with the field, it came into its own after 9/11 and the anthrax attacks. So kind of originated as the health aspect of national security concerns. These days, public health emergency preparedness covers health impacts of natural disasters, unnatural disasters, terrorism, and pandemics like COVID-19, which is probably what most people are most familiar with. And like other emergency management fields, public health emergency preparedness tries to make plans for how an agency or jurisdiction would prepare for disasters and how to respond to them. And crucially, it's also more than the professionals, because everyday people, nonprofits, and community organizations also do a lot of the work to protect public health when everything goes wrong. So now I'd just like to ask Julia a little bit, like just say a little about who you are, what kind of work you do, and maybe any thoughts you have on the community resilience side of preparedness.
Sorry, I was muted. My name is Julia Reynolds, and I work in public health in Oklahoma and have been working in public health preparedness for the past almost 4 years now. And basically, a lot of my role is working with volunteers to support the public health response. A lot of public health departments and preparedness departments in particular are really understaffed. So we depend very heavily on volunteers to help us during emergencies. And then before an emergency happens, we train volunteers on how they can support their community and stuff like that. And then did you ask another question, Austrian? I'm sorry.
Just sort of, I mean, no, that pretty much covers who you are and your background.
Okay.
I guess going off of the community partners and the volunteers, one of the things I think a lot about with disaster is its inequality. On the one hand, a disaster doesn't care who you are, a hurricane doesn't care who you voted for. However, anyone might experience a disaster, no one experiences it in the same way. So I think you have a nice perspective into this because of all the community work that you do. And so just could we talk a little bit about who is most vulnerable during disasters, be they natural, man-made, disease, etc. And what is the public health emergency preparedness field's attempts to account for these disparities?
Yeah. So who's typically most vulnerable to disasters? It kind of it can depend on the specific disaster. Like when I think about tornadoes, I think some of the most vulnerable people are going to be people who live in mobile home parks, for example. But I think overall, very consistently, the groups who are most vulnerable to disasters are like people who require medical equipment that needs power. They're very vulnerable. Infants, the elderly, people living in poverty, people with disabilities, people who speak English as a second language, and then maybe people who don't have US citizenship. I think all these things tend to make someone more vulnerable during a disaster. Like what we definitely see is people who don't have citizenship here, they don't always feel safe seeking help from local public health offices. And then, people who are living in poverty, they oftentimes, they don't have the resources to be able to recuperate after a disaster. So things like that. And how the public health emergency preparedness field tries to account for this, I would say, unfortunately, oftentimes the field can fail at accounting for this. I think whenever it comes to general emergency management, they're just kind of oftentimes focused on saving the largest amount of people they can in the shortest amount of time. And they're oftentimes understaffed and underfunded. So they tend to put a lot of pressure on community members to be prepared and almost be able to like fight for themselves in a way, at least for the first 72 hours following a disaster. That's messaging that's put out a lot in Oklahoma is the first 72 is on you. You need to be able to be self-sufficient because might not be able to help you. Or like, you know, if you talk to some of the main organizations that set up emergency shelters after a disaster, and you ask them like, hey, is this shelter, like, do you make sure your shelters are accessible? Do you make sure your shelters will have food for infants? Do you make sure your shelters will have translators? They kind of will look at you blankly and be like, well, we figure that out when we get there if we need to. Yeah, so that kind of can be the attitude sometimes.
Yeah. Improvisation is a pretty terrifying strategy, to admit that that's your approach to figuring out how to care for vulnerable people when a disaster strikes.
Right. So some things that I kind of try to do is like, I mean, so well, now I'm kind of getting into the Trump cuts and stuff, and I don't know.
Yeah,
We should
we'll get to that
okay.
at some point. Yeah.
Okay.
For sort of the field's general approach to vulnerability and accounting for who does need potentially extra attention or extra consideration in the planning process. The one framework that I remember being used a lot in the field is just what they call AFN, or access and functional needs, which is supposed to account for sort of who might face barriers to being able to evacuate, being able to go to a shelter, being able to access vaccines or public health or just any other healthcare during a disaster. And the kind of people that they think about in that case are people with disabilities and also people who don't speak English or speak English as a second language, because both of those are access or functional needs when it comes to receiving services. However, this does tend to be a pretty limited framework. And while I do think it's good that at least public health preparedness does account for this, it's pretty limited. It's very almost after the fact, you know, we've built this system and now we're going to see how we can tweak it a little bit to make sure that some people can still access it after we realize that they can't.
Right.
But access is built in kind of as an afterthought or as an addition rather than as a central concern from the beginning of the planning process.
Right.
And I know you've talked a bit about just problems with the planning process and who's actually considered. And so I guess just to talk a little bit about preparedness planning, because people may not know what that looks like. But in theory, public health departments and really a lot of other city agencies, companies as well, hospitals as well, emergency management offices, they make a lot of plans. They do a lot of exercises. They do a lot of trainings to kind of anticipate disaster situations ahead of time. But a lot of this, your plan is only as good as who you think it might account for. And your plan is only as good as who's actually able to follow it. And everyone says, you know, no plan survives contact with reality. That's a given. But in terms of contingency planning, often in exercises, we're trying to imagine, you know, the worst thing that could happen. Or you've got a pandemic, but now you've got another thing on top of it. You've got a hurricane, and now you have a dam breaking. There's always a way to make the exercise worse. So you do try to plan for those worst case scenarios, and yet we're always falling short. And I guess just could you talk a little about your experience in the planning and contingency planning spaces?
Yeah. Oh, that's a really good question. I think so. A lot of times when it comes to planning within public health emergency preparedness, the planner is often siloed and they're just kind of working on their own, and maybe they consult other emergency managers. But I think oftentimes the planner isn't encouraged to use the resources readily available to them, like their own coworkers, like the different nurses who are working in the WIC clinic, for example, or like going out and talking to the community health workers and like saying, hey, can you help me get some kind of focus group together so we can see if this plan is going to be helpful for a wide variety of people. And so I feel like that's kind of a problem. And I know the health department I work for, we had some mass vaccine plans laid out, and we wanted to talk with people who were deaf or hard of hearing, who are blind or have low vision, and then reached out to people who served unhoused communities and asked them like, hey, what are we missing in our plan? How do you think we could improve? And just really open the plan up to feedback. And I just think that needs to happen more often. I've been in exercises where, you know, when we're testing out, like, okay, how are we going to respond if this awful thing happens in the hospitals, like flooding and all these things. And sometimes if you throw in other factors like, oh, what will you do if like someone who doesn't speak English walks in? Sometimes you'll be met with like, oh, well, we don't really have the capabilities for that, so we're not going to exercise for that or test for that right now. So yeah, I'll notice sometimes in exercises we will kind of create unrealistic scenarios, because I've been to so many community events, just vaccine events, where yeah, people are speaking other languages, people are blind or have low vision, and are met with like surprise, like, oh, and whenever like everyone needs to be factored in to all of this. So yeah.
Yeah, and the improv response really only goes so far, because there are things that you can change on the spot. And I remember doing that, like during COVID testing mass drive-through operations in early 2022, we didn't have Spanish language forms at first. And so we were trying to either translate on the spot while getting people to sign intake forms for testing, or telling them that we'd have forms later, but we didn't have them yet. And
yeah,
you can do that kind of improvisation, but it also diminishes the quality of care that you're able to provide, because it's clear that you're always on the back foot and you're just barely keeping up, and you're trying to serve people, and the people are showing up and they need services, and you've just barely, I don't know, Google translated your form into Spanish, and your workers
right,
mostly don't speak Spanish.
right.
And that's not really very sustainable, and it's not very public health. It's not serving the public terribly well.
Right. Or people even have, I've seen this a lot. People have the attitude of like, oh, their child can just translate for them.
Right.
And it's like, that doesn't seem very ethical to force a child into that position to translate like medical information. But that can often be the attitude. So
Yeah. And
yeah.
then translation is another thing that you just sort of, you want to tack on at the end as kind of a nice thing. If we can get it, it would be nice. Or, you know, scrambling at the last minute because you don't have any vaccine information in Vietnamese. Well, maybe you need to put that work in up front. And I think with planning, a lot of the problems start with the very early stages of planning because of who's not in the room.
Yes,
And
exactly.
I was thinking of, I don't think I was actually present at an exercise for this specifically, but in terms of things like decontamination after a potential chemical attack, I remember a conversation about how you would need to get a bunch of different community members to come to your decontamination exercise so that you could make sure that, for instance, the people running the decontamination knew how to handle a wheelchair user if they needed to receive decontamination after a chemical exposure. And on the one hand, it's good that they thought of that. And it's good that the health department realized that people who use wheelchairs might, in fact, be part of the population needing to receive decontamination. But you're only inviting them as to test out your exercise. You're
Right.
not inviting them to help make the plans, and you're not talking to them about what kind of preparedness they're already doing in their everyday life, or even what their concerns are outside of, can I get from my wheelchair onto the decontamination table and then out of the decontamination tent?
Yeah, yeah. I really love how you pointed out like what kind of preparedness people are already doing in their everyday lives, because I think that's another thing we can improve on when it comes to public health emergency preparedness is working with people in the community who are already preparing their fellow community members. And I've been working more with this group called Supporting Minorities with Disabilities, and it's just this amazing organization that's all about supporting families where members of the family have disabilities, and supporting self-advocates, and just offering people respite and resources, and they're really amazing. And I got to teach people at their recent sibling camp. I got to teach people CPR and first aid. And so it's like they're already doing so much preparedness work in just building community alone. Because I think so much of being prepared for a disaster is having people you can call, and is having people who can help you get resources if you don't have any. And so I think it's really on us public health preparedness officials to find those organizations who are doing that work, to find those people who are interested and to support them where they're at. And yeah.
I think the learning from the people who are already doing the work at the community level is such an underrated lesson for the public health preparedness field, and really for all professional healthcare and other fields. Because I do think a lot of the dynamic that you get, the paradigm that you get in access and functional needs and things like that is, it's almost like, well, we know that you need extra help, and we kind of feel like we're doing you a favor by including your concerns, because we don't actually want you to die, but it feels like we're going out of our way. We're doing extra work to think of you. Or in the Oklahoma homebound vaccination program, you could receive vaccinations in your house if you are unable to leave and come to a vaccination site. And that's a good program, but sometimes I did feel like it was almost portrayed as, we're doing a favor to you. We're going out of our way to provide care to you, whereas everyone else is able to receive care just without our extra effort. And I think that reframing that to include, or to build the planning process from the beginning with marginalized communities, with non-native English speakers, with disabled communities, would really do a lot just to strengthen the plans that are made, because they would actually account for people, and also to teach the public health field a lot about the type of preparedness that people need and are actually doing. And I think that seeing AFN work or other equity-focused public health work as extra or gratuitous or just done out of the kindness of one's heart really undermines the actual advantages that you could get out of incorporating all those perspectives.
Yeah, I think you're very right about that. Yeah.
And then I think from here, we should get into more of the equity issues, because there really are a lot. Having established the importance of considering equity in public health preparedness and in terms of who is worst affected when a disaster hits, let's talk about how equity is not popular right now.
Right.
So I guess just to set the stage of the general dismantling of government departments and services and funds in public health and emergency preparedness, this has big implications. 20,000 employees have already been fired from HHS. FEMA, the Federal Emergency Management Agency, has lost 1/3 of its full-time staff. Trump has talked about eliminating it entirely. Last month, its director was fired after saying that he didn't think FEMA should be eliminated. And the general disaster preparedness model that seems to be pushed right now is just pushing all responsibility onto the states and leaving them to handle their own disasters without federal assistance, which is just frankly not going to be possible. And then at the same time, other preparedness funding, either from CDC, the hospital preparedness program, other parts of HHS have also been canceled or rescinded. So this is potentially catastrophic for public health emergency preparedness and for just emergency management as a field in general. And it's really hard to see how all that funding and oversight and training and support could even ever be rebuilt back in a thorough way, given how much is being destroyed. And people still are going to be doing that work at the local level. But the local level is going to look different without all that federal support. So, yeah, if you could talk a bit about what's going on there.
Yeah, I think like at the local level, we depend so much on federal funding. And so there's just been so much uncertainty and fear because like we really don't know how long we'll have our jobs. We don't know how much we're going to be impacted by all the cuts. And I know at the state level, uh, our governor had already had a moratorium on hiring. So like anytime a state health department employee left, they weren't allowed to replace them. So they were already understaffed. And now they're talking about potentially firing a lot of the workers. Because our governor, he wants to have his own Doge program. And so then, yeah, at the local level, again, we depend so much on federal funding. So, and our partners, the people we work with who have really strong connections in the community and who have been helping community members for decades, they depend a lot on federal grant funding. So everyone right now is just feeling pretty scared. And yeah, a lot of really great people are leaving their jobs because they don't know how much longer they'll have it. So public health already had really high turnover rates during the pandemic because of burnout. And then now it's like there's this new wave of people leaving because either they've been let go or there's just too much uncertainty and they don't know if they can stay. Which is making, I think, it even harder for community members to be able to trust public health officials. Like it already took, it's a lot of hard work to build those relationships out in the community and to help show people like, no, we are here to serve you. We want to help you. And then when these people who've been telling you that are all of a sudden gone, and all these programs that they helped connect you with are all of a sudden not there. It's yeah, it's just it's very frustrating right now, and yeah. So
Yeah.
we'll see.
No, the
Yeah.
lack of continuity is something I think people don't realize with sort of a government agency, but one person running a program or maintaining a relationship from the public health department to the community, it might be gone as soon as that person is gone.
Yeah.
There's a lot of programs that are upheld by very few people doing a lot of committed work. And without them, it doesn't get done. And especially if it was in any way connected to anything that can be maligned as equity focused, it's not going to
Right.
get done either because they're not allowed to do it anymore. They're afraid to do it. They don't have the time to do it. They don't have the funding to do it. They don't have the energy. They don't have the institutional support. It's not a grant requirement, so it won't get done.
Right.
Because a lot of times you really are pressed for what you can focus on because of the staffing constraints and because of the funding constraints. And if something isn't required, it's not getting done. If that data isn't required, it's not getting collected.
Yeah, that is so true. And I love what you said about how oftentimes like it could be one person running a whole program like that is how it is. Like public health is just so underfunded. It really takes like a few passionate individuals who really care about their community. And when they leave, everyone's just scrambling, you know? So
Yeah.
yeah.
No,
Yeah.
I'm not excited to see the future of disasters as people's programs lose funding, as states don't get their funding. And apparently they've already cut just like $12 billion in overall support to state and local government, and
Hmm.
not just healthcare, not just public health, but in general. There's a huge emphasis on turning responsibility for everything over to the states while simultaneously stripping them of all the financial support to take on that responsibility, which
Right.
is really only going to blow up in everyone's faces. But unfortunately, the people who it's going to blow up for the most are the people who, as we've talked about, were already only an afterthought.
Yeah. 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 I think Oklahoma, it kind of feels like a rough position because our governor, he really doesn't like funding anything that has to do with equity and things like that. So uh he really admires Trump. So it kind of feels like we can't at least look to our governor to help us out during this time and try to figure out ways we can get through this tough period. So yeah, yeah, it's been a lot.
One of the really ironic things that I've noticed about all of the backlash against the concept of equity, especially in the preparedness field, is that equity does not only mean we're helping non-white people who didn't necessarily deserve it and aren't in this country legally, which is how they're painting it overall as a term, when ironically, if you look at programs like the Building Resilient Infrastructure and Communities BRIC program, which is being cut right now, that was a program established by Trump, and its goal was to help under-resourced communities build resilience against disasters. And a lot of the funding earmarked through that program was going to small, white, rural, Trump voting communities because they aren't wealthy. They do not have the money to invest in preparedness. They don't have the money to upgrade their infrastructure. They know that if a storm comes through, their people are dying and they needed this money, and they're no longer getting this money because it was earmarked through equity.
Yeah.
And just
Yeah.
the really cruel irony of not realizing that sometimes equity is you. Sometimes
Yeah.
you are the person who's vulnerable. And well, now you're not. Now you're not
Yeah.
getting that help anymore.
Yeah. And kind of speaking of that, the sometimes equity is you and sometimes you are the person who's going to be vulnerable. Like, you know, I know people who voted for Trump, and I kind of am always expecting the latest thing he's done or said. I'm like, surely now they're upset with him, or surely now they disagree with him. And I know one person where his livelihood is being threatened. And he just kept telling me like, but I like Trump and I like what he's doing. And if I have to lose my job because of all this, so be it. And and this is someone, he's so involved in the community. He's doing a lot of great work, and he's such a hard worker. And I'm like, surely you don't think you deserve to be fired. But yeah, it's very interesting how ingrained the anti-government mindset can be, even with people who might work in the
In
government and
right.
and love their job. And yeah, it's just been very interesting to see. It's been very interesting to see.
Yeah. No, because I think a lot of the turning responsibility over to the states, or, it seems to jive really well with the idea that, we don't want to depend on the government. The government's too big. The states should, states' rights. We should do our own thing. Can you do your own thing?
Right.
Can you still deliver the services that you were delivering it without federal support?
Right.
And if you can't, are you just going to turn around and say, well, those services weren't worth it anyway?
Right.
And I guess
Right.
I guess my job wasn't very valuable, but
Right.
it was. So that the cognitive dissonance is really remarkable there.
Right, right. Or even people who like we have a program where I work where we provide people with free produce in areas with really high rates of food insecurity. And there are people there who come up and they're wearing a MAGA hat. And you're kind of like, huh, like, do you know that all the funding from this is being threatened for this program is being threatened right now? And yeah, it's very interesting to see.
Yeah.
Yeah.
I think similarly with the dismantling or the threatened restructuring, quote unquote, of FEMA, where a lot of people, and many times justifiably, really don't like FEMA. And at the local level, a lot of people, they don't look forward to FEMA coming in. They don't talk about collaborating with FEMA in a positive way. And a
No.
lot of that is justified by FEMA having often been incompetent or very slow to respond, or, giving people formaldehyde trailers after Katrina. FEMA has done a lot wrong, and a lot of people don't trust it, including preparedness folks. And on the one hand, yeah, they earned that reputation. On the other hand, what is your real plan to do without them? Like, it's easy to say, oh, yeah, I don't like FEMA. Yeah, I am glad Trump is restructuring it. I do kind of think it should be dismantled. It is wasteful and bad. But then you look at why they think it's wasteful and bad. And Trump's executive order on restructuring of FEMA is just saying things like, oh, well, FEMA is wasteful and full of fraud because they provide services to undocumented immigrants instead of real citizens. So they're wasting your taxpayer money. It's like you're advocating for people to die.
Yeah.
And if that's the kind of preparedness that makes you feel safe in a disaster, bad news for you, because the kind of preparedness that intends to leave people out to die will also not protect you.
Yeah.
And
that is so true.
it doesn't mean you have to defend everything FEMA has ever done. I personally am not a huge fan of a lot of the way that agency works. But its dismantling is just emblematic of so much other damage being done.
Right.
And just how less prepared we're all going to be in the case of really any disaster.
Right. Yeah. Which I think that kind of goes into like, what are things we can do to help make ourselves more prepared, our communities more prepared, in the absence of this help. And I know, like, I get to work with Medical Reserve Corps volunteers, and these are medical and non-medical volunteers who support the public health response. And we try to offer them trainings very regularly on like CPR and first aid, community emergency response team trainings. So like basically how to respond to a disaster and help your neighbors in a disaster. Things like bleeding control trainings, how to use a tourniquet, how to stop a major wound. And I think it really helps to get more involved with things like that, because if FEMA isn't going to be there to support us, and if our governments are going to be even more under-resourced, we're going to just need to depend on our neighbors, I think, more and more. So, yeah.
The ironic thing about emergency management and public health emergency preparedness by extension is it has this really strange relationship to community self-organization and things like mutual aid preparedness, and just the idea that on the one hand, as you said earlier, the first 72 are up to you. They expect people to essentially be on their own for the first 72 hours after, let's say, a major tornado, a hurricane, an earthquake. And at the same time, there's this real distrust and disdain for local unofficial volunteer responses, especially from emergency management types who it's an interesting field because it's very ideologically aligned with law enforcement, even though they see themselves as something different.
Yeah.
But they're very disdainful towards community attempts to organize and prepare on their own. And at
Yeah.
the same time, they expect people to be doing that work. And
Yeah.
so people are, and on the other hand, just saying the first 72 is up to you, the kind of person that is able to just be on their own for 72 hours and be self-sufficient and not really need anything. And just, after 72 hours, FEMA might show up and they can, send you a little boat and get you out of your flooded house.
Right.
Okay, what if you're reliant on medications that need to be refrigerated? What if you're unable to move without a wheelchair that needs power? What if
Right.
you can't evacuate? And I think that, especially with the evacuation question, something else we're going to be seeing a lot more of as support is cut is people being blamed for whatever happens to them during a disaster. Because I think this first 72 is up to you. Framing is kind of a way to shift the responsibility already of,
Yeah.
really you should have just not been hit by the disaster. And so the fact that we have to do preparedness and response at all is kind of on you because you should have just not been affected by that disaster. And I think we're going to be seeing a lot more of that. But there is this weird tension between wanting people to do everything themselves and also wanting them to defer to the experts all the time.
Right. Yeah. Yeah. It's like, yeah, be self-reliant, but don't organize to help each other. It's kind of like that attitude. I think something I didn't know before, like joining the preparedness field, is that most people in emergency management are police officers. And so I think within policing, at least with Oklahoma, like I know multiple people who've been through the different police academies here and who have been cops or are cops, and they're taught in their training to fear the people they're serving. And so I think sometimes there can be this us versus them mindset within law enforcement. And so yeah, I don't want to I think it's I feel like a lot of law enforcement, they've seen a lot of awful things and have experienced a lot of trauma, and then are very fearful of the community they serve. And so yeah, it's that interesting tension that you're pointing out, where they're wanting people to be self-reliant, to be able to take care of themselves, but then, when the Cajun Navy shows up, they get really upset.
They hate the Cajun Navy
right.
for some reason. Every emergency management training, when they talk about, like, because to them, I think the role of the community in emergency response in the ideal form, from the perspective of the people making the plans, is comply with orders, don't panic, and really just sort of be moved around like pieces on a board. Okay, we'll set up a shelter here, we'll set up an evacuation route here, and the people will go there.
Yeah.
What if they don't? What if they can't? And that is really just treated as sort of an inconvenient like possibility in the planning process. And it's not something that people want to think about. And it's not, ideally the ideal community is compliant, and that is simply not the case. And especially in public health, if your vaccination plan, for instance, is we'll set up a vaccination location and everyone will come and they'll all get vaccinated and it'll be
Yeah.
fine. That's so out of touch with reality. It's a bit funny.
Yeah. 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 Definitely. Definitely.
But yeah, there's no, I think, and definitely having the law enforcement overlap with emergency management does a lot of damage to the willingness to build community relations, the willingness to even consider the types of communities who you're serving and how their vulnerability might affect their disaster response. The idea, I think, that there's only sort of one correct way to respond to disaster, which is usually evacuate if you can, or just be very self-sufficient, don't have any inconvenient needs,
Right.
take care of yourself. Don't organize with your community though, because you're untrained and you're unprofessional and you might accidentally put yourself in danger, as if
Mhm.
waiting 72 hours to maybe be rescued by FEMA was a feasible alternative.
Right. Right. Yeah.
But there's just public health emergency preparedness, I think, does somewhat better than emergency management as a general field. On the other hand, most disaster responses outside of pandemics are not being coordinated overall by public health people. They're being coordinated by emergency managers and
Right.
emergency response people who often have a much more law enforcement mentality and also much more concern for, say, property rather than life. And
Right.
life is supposed to be primary, but property is right up there on the list.
Right. Right. Yeah. Yeah. And in those spaces, when you try to bring up things about like, hey, like, how can people prepare to be 72 hours like on their own and isolated whenever they don't know where their next meal is coming from? How can we
Right.
expect them to do this? How can we expect them to buy an expensive preparedness kit and stock up on food when they don't even have food for tomorrow? Like, why would they do that? And then you're just kind of met with silence and kind of this attitude of,
Yeah.
well, it's not my problem.
Right. Like those aren't really the people that we're doing preparedness for. Those are not the community members who we're trying to save, frankly.
Yeah. Yeah.
And the other thing that I think about with the first 72 is up to you is how many disasters are there really where you can just sit out 72 hours while you wait for your state and federal disaster preparedness team to assemble some sort of incident response team and show up and bail you out? Maybe a flood, I guess, maybe the aftermath of a hurricane, but a wildfire? You don't have
Right.
72 hours. Your house is burning. You're out of
Mhm.
there. You're stuck on the highway. You're stuck in the parking lot of a building while everything around you, which happened to people in the Paradise, California fires in 2018, really, you don't have 72 hours.
Yeah.
It's up to you or it's nothing. And if they're not coming, it is up to the communities. But in a lot of disasters, it's really not obvious what to do. And then pandemics, of course, are not, you don't get help after 72 hours and then it's all good. That's, as we've seen, that's a years-long endeavor. And, you're only getting help for some of it, probably.
Right.
And
Right.
then things like uh, climate disasters, which are a whole other aspect of all of this, but things like extreme heat waves, not every emergency management team might recognize that as a disaster, because it's not damaging infrastructure, it's damaging people who are particularly vulnerable. And so from the public health side, we absolutely see that as a disaster, but you don't have 72 hours if you're unhoused and it's 115 degrees outside and you don't have anywhere to go. You don't really have 72 hours to wander around and figure out if you can cool down somewhere.
Right. Right. Yeah.
And so it's a really strange mentality to bring to the idea that we should help people, but we won't help you right away. And you should be able to weather it on your own but we don't want you to be too self-sufficient because then
Right.
you might defy the experts.
Yes, yes, yes. And put yourself in danger and be another person that we're going to have to save. That's kind of the
Right.
argument they
Right.
use a
That,
lot.
yes.
Yeah.
To clarify, yes, that is why they don't like it when people, for instance, organize boats in a flood situation to try to bail out their neighbors, because you might not really know what you're doing and you also might get stuck, and then there's more people in trouble who need to be rescued. That's
Yeah.
the argument. On the other hand, I think it's a little bit out of touch with just human nature. People are not going to sit around if they feel panicked and trapped and they think they can get out. They're going to try to get out.
Yeah. Yeah. Definitely. Definitely. I think bringing up extreme heat waves is interesting because I was at an emergency managers meeting where we were talking about what are some of the biggest threats and over the next few years, and the things mentioned by others would be like civil unrest and things like that, whereas I'm worried about climate change, and I'm worried about like how economic inequality just keeps getting worse and worse. So it's getting harder and harder for people to be able to respond to disasters and help themselves and help their community members. And then when you say things like that, you're kind of met with like eye rolls, you know?
Mhm.
And so I think, yeah, there's just kind of an interesting mindset in Oklahoma, because in some ways, like I think we have like the third most federally declared disasters every
Yeah.
year. And so we're very used to working with the federal government in that way, and used to responding to disasters. But I think we're still pretty resistant to seeing climate change as a disaster, to seeing to seeing other ways we can respond and
Mhm.
other ways to view what's happening. So
Yeah.
yeah.
No, climate change is an interesting one because that was one of the things I worked on when I was in Oklahoma, and I did a lot of research on what are the climate threats Oklahoma is going to be facing and what are the health consequences. And extreme heat really is one of the main things. And it's a strange thing to consider as a disaster because it doesn't really strike with the visual or physical destruction of a tornado, for instance, but it sends a lot of people to the hospital. It kills a lot of people who can't go out, can't go inside, can't air condition their houses, have different medical conditions that make them more sensitive to heat.
Mhm.
And it's really hard to add that into the pantheon of disasters that people are used to responding to in Oklahoma, I think, because it's not sort of flashy. You don't see the trail of destruction. And with a tornado, it's pretty clear the disaster came, it went.
Yeah.
Here's the aftermath.
Yeah.
And that's not the case with climate disasters. They're not going to come and go. They're going to just keep coming, and the aftermath will be with us as the next disaster comes around. And they don't have the same sort of evidence. Like they don't have the same destruction. And you don't even have the same concept of being able to rebuild after, because there isn't really an after, which is
Yeah.
also an interesting thing. And another thing about the federal cuts to preparedness and disaster spending is a lot of what is still getting funds, even in recent things with recent tornadoes, or recent state requests for aid. They're still getting the funds to respond to the disaster while it's happening, but they're not getting the funds for the reconstruction and recovery.
Wow.
So in some ways, what's being handed over to states isn't necessarily the federal government will completely turn its back, although it may largely turn its back while the actual tornado is touching down, while the hurricane is pummeling your city. But you're not getting help for rebuilding and you're not getting help for resilience. And there's no sort of future-oriented post-disaster emphasis. And in things like FEMA's guidance for how jurisdictions should be making hazard mitigation plans, they only added climate change into their guidance in 2023, and they've already taken it out again.
Oh, wow.
And
Wow.
so you can write about projected future situations in your hazard mitigation plans when you're applying for funding and such, but not climate.
Wow. I mean, speaking of federal agencies removing a lot of their documents and stuff, I think that's also definitely a stressor for people in public health preparedness, because I used to utilize the CDC website all the time to for different reports, for different projects, to conduct public outreach. They have some really great infographics and things like that. And now, like, it feels like so many of the pages I used have been taken down. Now some of the things they're saying about the COVID vaccine is different from the guidance from before.
Yeah.
And so it gets pretty dicey because, you know, throughout the whole pandemic, we were like, oh man, why aren't people just listening to the CDC? Like, just go to the CDC website. Like, you will get clear information there. And now you have different COVID-19 vaccine guidance. And it feels pretty messy. It feels like we keep taking steps back in getting public trust.
Yeah.
Yeah.
No, and there was already a lot of reasons that people didn't trust public health institutions or emergency management institutions or the government at all. And now there's sort of even less to point to for saying, yeah, well, at least you can trust this CDC page. At least you can trust what they're saying. That's not the case anymore. And
Right.
a lot of I mean, RFK himself was identified as a major source of COVID misinformation during the pandemic and identified as one of the major causes of all of these different conspiracy theories. And now he's HHS. That's who you're pointing to when you're sort of if you are to sort of reify the legitimacy of scientific institutions or government institutions, that's now who you're pointing to.
Right.
So if they had a lot of legitimacy to lose, which is a debatable point, they have far less now. And so at that point, where do you turn to? And I think just sort of, I guess, to wrap up the webinar on the note of when there is no one to turn to, what do we do instead? And what are sort of the options for community organizations or community organizing? How do we sort of become the preparedness experts, which many of us already in our own ways were in our communities? But what does that look like when truly no one is coming to save us?
Right. I think I'm pretty biased towards the Medical Reserve Corps because it's just such an amazing group of medical and non-medical volunteers who are trying to support public health in their community. And so I know some of our volunteers, like one of our doctors who's part of our group, he'll have just these free webinars for anyone who wants to join about like what to do during extreme heat events, or why sleep is important, and things like that, when I think so many Oklahomans don't get to have doctor's appointments. They honestly don't have insurance. They aren't able to take off of work to go to the doctor. And so having a health professional take the time to explain some of this really important information for free. I think that's been really great for members of our community. We offer like free life-saving trainings to people, like CPR and first aid, bleeding control training, things like that. And then also just work with a lot of different organizations in our community, like organizations that serve unhoused people, organizations that serve people who are deaf or hard of hearing, just to promote preparedness and things like that. And Austrian, I saw a really interesting question in the chat, and I am
Oh
curious what
yeah.
you
No,
think of it.
I think we will turn to the chat now just
Okay.
to look through it. So yeah, what did you want to
Okay.
respond to?
They said, does public health deserve public trust?
Well, as a public health person, does it?
Um, I don't know. I feel like saying yes would almost be like gaslighting people a little bit. I think it's hard when our health institutions in general have failed people so often. Like, you know, like our health institutions being major reasons some people had to go bankrupt. You know,
Mm-hmm.
like I think it's just such a sore spot for so many people, and very understandably so. And I think, I don't know. I mean, work like the local health departments I've gotten to work with, I think they're definitely deserving of trust. But yeah, I think it gets pretty confusing when the CDC's putting out some conflicting information or taking back some information they used to broadcast. And it's just becoming more important than ever to really embed yourself in your community and be able to find health professionals you trust, that
Mm-hmm.
you can ask direct your questions towards and things like that. What do you think?
I guess to ask a bunch of follow-up questions, sort of what are we conceptualizing as public health? Is it the
Hmm.
institutions? Do they have a monopoly on the definition of and enactment of public health? Is public health not also the ways in which we organize to keep ourselves safe and try to improve our own health? Whether this
Ooh.
is things like putting more incinerators in non-white neighborhoods, that's a public health fight. That kind
Mm-hmm.
of public health deserves trust and support.
Yes.
But the institutions, especially historically, deserve scrutiny. And if they're
Yes.
going to demand trust, then they do need to earn it. And you
Yeah.
can't really say to people like, just get over to Tuskegee. We're all different now. Are you? Are you? And I think a lot of institutions, being institutions, are notoriously resistant to that kind of accountability. And I'm also not sure that there's a good framework for what that kind of accountability looks like. And I think I believe in public health in terms of the work that needs to be done and in terms of the values of health and
Mm-hmm.
resiliency and well-being and the right to live in a safe and clean environment.
Mm-hmm.
But a lot of the most valuable public health work, to me, takes place among communities, sometimes in partnership with local health departments, with local nonprofits or groups that are also working toward the same goals. You know, if you have doctors or people who are trying to help you upgrade your infrastructure or people who are helping you do air quality monitoring, those public health professionals are serving a good role and they are contributing to public health. But I think those relationships matter more than just saying, yeah, you should trust the institutions. You want to trust the CDC website right now, which is
Right.
saying that COVID was definitely a lab leak? It's going to be, I mean, I think there's also a lot of questions that people need to ask themselves who have been responding to conspiracies or like public health anxieties or distrust in the systems by saying, no, no, you have to trust the experts. And the experts that they point to, well, those are now full of COVID deniers, vaccine deniers, people who are, you know, RFK aligned and other appointees running CDC and other institutions. Do you still want to point to those? Are those institutions in and of themselves bastions of health and security? Or did you just like the people who were running them at the time?
Right, right. Yeah. Yeah. We're in a really really kind of scary spot right now, I feel like. And I was wondering if you could talk about some of the research you did on misinformation.
Oh, yeah, this was back during 2020, 2021, 2022, I guess. Uh more when the COVID response was still at its peak and ongoing. And I was researching COVID misinformation and sort of how to respond to that because so, I mean, it's an issue everywhere. It was absolutely an issue in Oklahoma, and our vaccine uptake rates were not great. And, you know, we were trying to figure out how to arrange our communications. And one of the interesting things that I saw during that research was some research was done or some organization identified that there were only about 10 major sources of what be they like Facebook accounts or Instagram accounts of people who were the central nodes of COVID misinformation, RFK Jr. being one of them. And if you could have cracked down on those particular nodes of disseminating information, you might have been able to stop a lot of the spread of online misinformation. Obviously, if you ban the people, they'll come back. Sometimes you create an embattlement complex and then it gets worse. But in theory, there weren't that many people who were responsible for spreading an unbelievable amount of misinformation. And the thing about it is also, you don't have to get everyone to believe that, you know, vaccines cause autism, or the COVID vaccine will put a microchip in you, or it will kill your unborn baby. Everyone doesn't have to believe that. All it really has to do is spread doubt and get people to question whether they should be engaging with, in this case, things like vaccines, public health measures in general. And they don't have to distrust it. They just have to think, well, it's easier if I just don't take any action because the action might be dangerous. And unfortunately, a lot of the time, what public health is asking is for people to take an action. And it's often easier to not take an action. And so it's not a very hard sell to say, well, you just don't know. It could be dangerous. Wouldn't you rather stay safe? And a lot of what misinformation appeals to is that concern about safety, which is often very genuine. And a lot of people who are like, oh, well, no, I don't necessarily believe this. I just don't want to make the wrong choice. I just don't want to put myself or my kids in danger. And I think that again, with the trust in institutions, if your response to this kind of thing as a public health professional is just to say, well, we're the experts and we're right, and you shouldn't be scared and you're silly, that's not going to convince anyone, and it's really probably mostly going to shame them into doubling down. And I think that that goes hand in hand with public health needing to realize why people don't trust it as an institution, and rather than just point and say, but the experts, trust the experts.
Right.
You really have to engage with people and their fear, and you have to prove that you are trustworthy. It is very hard for an untrusted institution to demand people's trust when people feel that it remains unearned.
Right, right. And then I think in public health, like there were so many people who felt so hurt and so betrayed that people weren't getting vaccinated. And And I think that's really fair. You know, I work with people who they were working like way overtime every single week, like working their butts off, like endangering themselves to try to make sure everyone was as safe as they could be, to try to get this vaccine out as quickly as possible to as many people as possible. And then to sometimes be met with hatred at some of these events. I think it, you know, it was, yeah, very hard for them,
Yeah.
understandably so. And so it's interesting. It's like I think people within public health have to work through that pain that was caused and that confusion, and also need to accept the pain that our health systems have caused so many Americans, you know? So yeah, it's kind of a messy situation. And then yeah, we're all so separated, you know? And yeah, it's just hard when all the arguments are online, and it's really hard to have a productive conversation online and talk with people
Yeah.
about their fears. And yeah, so
I liked the doctor you mentioned who works with a local health department in Oklahoma who just does educational sessions and outreach to people and trainings. Like, I do think that education and skill building are one of the ways in which public health agencies can be really useful to the people around them. You have knowledge, you should share it.
yeah,
And people
yeah,
outside that institution also have knowledge. They can share
yes,
it. Public health
yes,
institutions should be listening.
yes.
There's a question I want to go to from a while ago. Just, has there ever been research to suggest that self-advocacy efforts may outpace some public health initiatives? I'm just going to say from the disability side, self-advocacy frequently and constantly outpaces public health initiatives because, like we've been talking about, public health and preparedness in general and healthcare in general lags so far behind on accounting for disability, for including disabled people in conversations, for really even caring what happens. And so in California, when the wildfires started to become just a constant yearly and ever worsening occurrence, it was the disability justice communities who already knew where to get N95 masks and who already knew how to try to make a homemade air purifier, or how to protect your house against particulate matter because your kids already have asthma. You already know how to do this work. Or making these community resource documents for if there's a power outage, here are the places you can go and still get power. Here are the people who have generators. Here's where you can plug in your electric wheelchair. And there's a huge amount of self-organizing among communities that are always being left behind because what else are you going to do?
Right, right.
And I think a lot of that would dovetail nicely with more public health support in an era where public health had funding to spare and was still interested in equity concerns. But I don't see public health initiatives really catching up or even incorporating a lot of community work at this moment, just either because they don't have the resources or they don't have the will or they're not allowed to. And the community work will go on. And I think it is really crucial to remember that people are already always doing our own emergency preparedness because the official responses have always been insufficient the whole time.
Yeah, that's very well said. Yeah, yeah.
But yeah. And I think we will probably wrap this up around there. Any last things that you would like to say before we finish this?
I don't think I have too much else to add. I think what gives me hope is that there are so many awesome grassroots organizations wherever you are doing beautiful work, and that you can join them at any time.
Yeah.
Yeah, I guess that's what I would add. Yeah.
Yeah. And even if there's not an organization, you might have neighbors. They might have skills and they might have needs. You might have skills and you might have needs. And it's pretty alarming to see all this dismantling of the federal government and see all of the ways in which institutionally disasters are being set up to get worse. But people have never been served all that well, and many people have never been served much at all by the existing structures. And so people have already been doing a lot of work to keep ourselves alive and safe when no help is going to come. And that's the kind of work that I think we need to turn to, especially right now.
Mm.
And yeah,
Beautifully said.
That's all for today. So thank you so much for coming on the podcast.
Thank you. It was
And
so
thank
nice
you
talking
for,
with you.
yeah. Thanks to everyone for watching and commenting in the chat. And yeah, that's it. I'll hand it back to the